All right. If anyone is still typing, that's absolutely fine. Feel free to continue what you are popping in the chat. If you do have any questions or any comments as we're going along, feel free to pop them in as we go. If you do have something you wish to contribute and you're brave enough to take your mic off mute, just pop your hand up and we'll circle around to anyone who wants to contribute verbally as well. Some people would prefer that rather than typing, and that is absolutely fine. Just a quick note though, this session is recorded, so if you are contributing verbally, just keep that in mind as well. So the general consensus is everyone that has popped something in the chat is an allied health assistant or working towards becoming an allied health assistant, which is fantastic. A lot of people have popped in there that they're looking to increase knowledge, looking at how they can expand their scope or increase their competencies, essentially. What is it they can be doing that they may not already be doing? Understanding a bit more about professional boundaries. And yeah, like what other things can we do that we may not already? So a little bit about me. I'm an allied health assistant myself. I'm also a lecturer at TAFE teaching the allied health assistants qualifications over here in Western Australia. One of my favourite units to actually teach is the supervision and delegation unit, which is a core unit now in the certificate for qualification. It is not a mandatory unit anymore at the moment in the certificate 3, though some organisations may be utilising it as an elective. The supervision and delegation unit is relatively new. It only got introduced about 3 or 4 years ago when the course got updated. So prior to that, anyone who completed their allied health assistance qualifications only had supervision and delegation components built in to other units that we did throughout our training. And it wasn't touched on in a huge amount of detail. This new supervision and delegation unit really dives quite deep into the scope of practice, those professional boundaries, effective delegation processes and whatnot. So for any of you who have done that qualification more recently, some of this you may have covered in your training in a bit more detail, or you may not have, depending on where you did your course. So as most of you are quite well aware, our scope of practice as an AHA, we need to have tasks delegated to us by our allied health professional. What tasks can we actually do? As that general rule, it's those lower skilled, routine, regular, common type activities that we get delegated. It's generally those programs that require a lot of repetition when we're doing those one-on-one activities or programs with a client or patient. Now, are we limited to just doing those common routine basic sort of tasks? Absolutely not. As the allied health assistant working in that organisation, it's up to that organisation to provide that upskilling beyond what we learn in our training that could be workplace specific so that we can actually work to a higher scope. The work still needs to be delegated to us. We need to be deemed as competent to do it, but it doesn't just have to be the mundane, daily, common routine sort of tasks. Can I just get you to pop in the chat what sort of disciplines we're working with for those of you who are willing to contribute in the chat? Are you mainly working with physios, OT, speech, psych, dietetics, nutrition? Just pop in the chat what sort of teams you're working alongside and receiving delegation from. Feel free to keep contributing to the chat as I continue yapping away. It's looking like we've got a nice variety so far in the chat of different disciplines that we're working with, which is fantastic. So with that, just as a bit more of a broad perspective, the programs essentially that we're being delegated, quite often it is a lot of repetition or practice of that same therapy program over a set number of sessions or weeks before the allied health professional does review. There is a common misconception around assessments and screening tools with AHAs. So quite often, well, as an AHA, we're not allowed to assess, we're not allowed to diagnose. I hope you're all very aware of that, as most of you are working in industry. We can't technically assess. So that quite often gets misjudged, essentially, by allied health professionals, that we can't conduct screening tools. As an AHA, we can, not all of them, but a lot of them, we can actually conduct the screening tool, because most of the time it's collecting the data. As long as we're not the ones making that judgment call from what the results of that screening tool are, then we're actually able to deliver it. There will be some variations where we're not able to, because it actually requires that clinical judgment reasoning on the go while they're conducting that assessment. But things like a 6-minute walk test, where we're literally recording data, there's essentially a script to follow as you're delivering that 6-minute walk test, and then you're passing that data back to the physio exercise phys to actually review that data and go, okay, this is what that means for that individual, this is how we move forward for them. So in terms of, we're not allowed to assess, but we can assist with assessments and screening tools by collecting the data for the allied health professional. So that's where there is a lot of grey area with some of that more advanced stuff that could be delegated to us that quite often isn't, because they don't see us as able to do any aspect of that. Now, where do I want to go from here? What other things we can assist with other than, say, assisting with those screening tool components? Most of you should be aware we can be the extra pair of hands. So say in a hospital setting, we've got a patient who's a to assist. We could be that second pair of hands for the allied health professional, rather than them having, say, 2 physios assisting someone to stand after a knee replacement. We're more cost effective. We can still do that work. It's easy for us to jump in and be that second pair of hands. The other areas that we jump in quite often, if they need that extra pair of hands when running groups, so that there's more supervision on the patients or participants in a group setting, we can be that extra pair of hands. On the flip side, this is something that quite often I have experienced in the paediatric community disability sort of setting. When you're working within that multidisciplinary team, this could potentially be relevant for the hospital setting, but I find it more relevant for community and disability-based. Now, quite often, particularly in paediatrics, if you've got a more complex child that you're working with, or they've got more complex communication needs in particular, you will often have 2 different discipline allied health professionals working together with that client to be able to actually achieve their therapy goals or work towards their outcomes. Now, it doesn't always have to be 2 different allied health professionals seeing that client. So for example, you've got a speech pathologist working with an OT with the client, because the speech pathologist is supporting communication while the OT is working on fine motor. The OT hasn't got the skills to support the communication aspect. The speech pathologist doesn't have those skills to support the fine motor aspect. So one of those allied health professions could be substituted by an AHA. So they've still got one allied health professional there that is supporting one aspect, whereas the allied health assistant could be supporting the other. Or if that allied health assistant, because we're all amazing, can become quite skilled, pick up the delegation from both different allied health professionals and be able to be a single person delivering that therapy program to an individual. So within that multidisciplinary team, when you've got multiple disciplines seeing a client or a patient at the same time, quite often we can substitute at least one of those allied health professionals to save on funding, particularly if they're NDIS clients or private. But yeah, because we've got that multidisciplinary approach as an AHA, as long as that work is delegated to us, it's within our scope there. Other things that we really can be doing quite effectively, unsupervised resource creation, as most of you probably are quite well aware of, sourcing quotes for equipment, all that sort of stuff, because that allows the allied health professional to work on more of their advanced scope, or to their full scope, and more complex tasks that they can't necessarily delegate. For all of this sort of stuff to be effective, though, the organisation has to have very clear delegation processes. If they don't have those clear delegation processes, then there becomes so much grey area, as the AHA. I have experienced it so many times myself. For example, I've had an OT turn around to me and say, you know the client, you know what you're doing, you'll work it out. I'm like, I need a therapy program to deliver to this client. I can't just go and see them without any handover. And they're like, I haven't got time to write one. Just go and see them, go and play in class with them. I'm like, but that's not clear delegation. You haven't actually given me any guidance as to what to do. You know, that's actually breaching your scope of practice as well, or your professional boundaries there. So when the clear delegation processes are not being followed or they're not effective, that can impact us as the AHA and understanding what we really need to do. Now, what we find most effective, generally, particularly in that paediatric AHA space, is those initial sessions often carried out by the allied health professional. If possible, have the allied health assistant there so they get to know the client, they build that rapport, but they also see that allied health professional in action. We're expanding our knowledge, our skills, and we're seeing how they manage the engagement, how they manage the behaviour, particularly of those paediatric clients who can be a bit more complex to get engaged in their therapy activities. But that allied health professionals hand over to us, particularly with some of those more complex clients, it shouldn't just be a therapy program. It shouldn't be go and do this exercise, this exercise, this exercise, or this activity, this one, this one. It should also have strategies in there for us to support that behaviour and engagement. And for everyone that they delegate to us, there should be additional information about things to watch out for, that are specific to that individual. Like if you've been given an exercise program to do with a particular patient and they've got a little nuance that they always do a particular exercise incorrectly, there should be a handover to us to say, hey, when doing this exercise, watch out for this, or cue them to do this. So that effective delegation from your allied health professional should have those additional supports in there, which also builds our skills, our observation techniques, our ability to manage different situations as well. Hopefully I'm making sense so far. I'm going to throw the chat open to anyone who has any specific questions or anyone who wants to contribute, ask anything. If you want to speak, raise your hand and take your mic off mute. If you want to contribute something in the chat or ask a specific question, go right ahead. Kylie, over to you. You're still on mute.
Sorry, that's a classic, isn't it? So, hi everyone, I'm working from Monash Health. We've got about 40 additional competencies, so 40, and we call them they're like additional tasks that AHAs can do. There's a lot in physio, but they're very niche. So it depends. I'm looking at Kim's comment there. So it depends really on where you're working, I feel. So in our acute setting, we've got AHAs can progress mobility for a certain cohort of clients in a certain situation. It's very, very structured. So it kind of depends on where you're working and what the appetite is for that sort of extended scope, I think. Do you agree, Corrie?
Yeah, definitely. So a lot of the hospital, or particularly government-based hospital settings, will have those competencies that you can get signed off on. However, you don't commonly see that in private practice, community-based settings, sort of situations, which can be a bit of a challenge to know what you can and can't do, or know where to go from there. Like, how do you advance your own skills? Which a lot of that does come from that clinical supervision element, where you are requesting further training in something, or you want to know more about this or that as you're going along. And something that I strongly reinforce to students, but also to placement sites and potential employers, is the allied health assistant courses teach you how to be an allied health assistant. They teach you the scope of practice, understanding those processes. Like, we receive delegation from the allied health professional, review those programs, seek clarification, make sure you understand what is being asked of you, deliver that program, and report back accordingly, whether it's in writing, verbal handovers, the things you're looking out for. We can teach basic programs, very general therapy programs, but a lot of the specifics for an organisation will be learned on the job as your delegated tasks actually in the workplace. So we can teach the basics, we can teach the foundations as an allied health assistant, but beyond that, it's really up to the workplace to go, okay, this is a competency we need for our essential cohort of clients. We need you to be able to do this. We need to upskill you in these areas. So yeah, it does come to workplace specifics. Those workplaces that have competencies that can sign you off, great. A lot of workplaces don't generally have that. So yeah, so thanks for contributing there, Kylie. All right, Kim.
Hi, yeah, so I'm in a hospital setting at GV Health in Shepparton. We do have, and I'm in the physio department, and we do have some competencies such as like the 6-minute walk test, the tug test. We do a CAN boot competency, the breast, education and that kind of thing. We're sort of looking at what's next for what other things that we could do, say the screening tools and things like that. I think the organisation would just like to see maybe some of the competency paperwork, like if Kylie was, able to maybe share some of their competencies or things like that, that we could have a look, that would help us progress here, because it's very difficult to do it yourself from scratch. Like it's always a bit high hanging fruit to get those things done. Yeah.
Yeah, so we're happy to share, but we've got so many. I just need to know what your organisation is requiring, like where, what do you want, kind of thing. Like,
yeah.
Yeah,
so
like what are the areas that you're looking at expanding into, I guess, is where we'd be looking at.
Yeah, so they were looking at expanding into ED for us to do the screening tests, the screenings in ED. We work in critical care, med, surge, rehab. We're across all of the wards. So we'd be looking at doing any of those physio competencies that will probably take some of the load off the physios.
I mean, data collection and screening and comprehensive screening is a part of the EA. It's part of our standard core business.
Yeah, but for some reason they keep getting stuck on how to do it, or what the training is, or what we need to know before they can allow us to do it, and what form it would be.
Well, maybe maybe throw someone that can speak to me if they need to, and we can probably thrash it out offline.
Yeah, sounds good.
Okay.
Thank you.
Just on that, Kim, and thanks, Kylie, for assisting there as well. So I'm just trying to find it in my learning materials here. Department of Health Queensland, they have pretty much all of their stuff available online, all of their competency documents. And for some reason, I can't find them at the moment because I've got copies of most of them. But yeah, Queensland Health has everything publicly available online if you search for it, unless they've removed access to everything now. But another one to look at for additional resources because I have a lot as well. Thank you. All right. Before I jump over to the chat with Evan's comment there, did anyone else have anything they would like to verbally ask or contribute there? All right, we'll quickly just jump to Karen's comment there. In SA Health, they're looking at implementing a new AHA framework. So each local health network is currently working to develop the CTIs, but finding it difficult to determine paediatric specific CTIs. Might be worth developing if you have any suggestions. Karen, is that paediatric CTIs for hospital-based settings, or is it more disability community-based? I'll let you pop that in the chat while I just jump over to Evan's comment here. So the organisation looking at the viability and ethics of AHAs being essentially the eyes on the ground with AHPs remotely guiding. Am I reading that correctly, Evan? So the AHAs are physically on the ground, AHPs are guiding remotely via telehealth video call.
Yes. So essentially what we're looking at is we have people on King Island in Tasmania, for example, and it's really hard to get out to them in person. But what we can do, and other areas of Tasmania, particularly on the West Coast, and what we can do is send an AHA, which is far more cost effective, to these clients, and they could be, and so instead of the clients using the digital platform directly with the OT, what they can do is have the OT guide the AHA through the conditions, the living conditions and the environment, and the OT could specifically ask them to measure certain things, or to zoom in or zoom out, or just to walk them around the house and show them other parts of it as an example, or show them how they perform certain tests. So we're kind of in a grey area, and we have people who are open to it and people who are less open to it, and we're trying to find where does this sit in terms of practicing ethically and appropriate use of an AHA. So AHAs are new to us, to give just some context.
Yeah, that's a really great question or great statement there, Evan. I actually recently was on a panel with Sarah, the Rural and Remote Allied Health Services, for an organisation in regional remote New South Wales that were looking at doing the same thing. Utilising AHPs on the ground that know the community, that are physically there, and having the AHP remotely supervise them. But it's not even really remote supervision, it is kind of direct supervision because they are there. It's just digitally there instead of physically there. So yeah, essentially it's the AHA is their second pair of hands, but the OT is still making those clinical decisions, and they're just getting the AHA to move around or take a measurement for them. So yes, there will be some grey areas, but if the OT is actually present for essentially that whole session via that telehealth sort of situation, then that would be relatively appropriate for most situations. Does anyone else have any experience working in that sort of setting? I've actually had to carry out assessment tools with clients in that sort of situation because we were very short on allied health professionals, and that's how we had to do it. But yeah, Kylie.
We had to do that during COVID. So I was out there with the video, and the professionals were in the office, and also for student assessments we did the same thing, kind of with the assessors watching from the video. So it's possible, but I think after COVID we eased it back, so it sort of went forwards and then went backwards a little bit.
So our preference is always face to face, obviously.
Yeah, of course.
Always. And we're just thinking that this might be a suitable option for some of our clients who are maybe at more risk. So we do a lot of aged care, and it's hard to get through to everybody, but if we can divide and conquer, and we'd obviously train our AHA to be able to perform this function as well, and to know what the OT is looking for. They've already shadowed the OT and know what's involved and are aware of the processes, and we'll be developing lists. But what I've noticed personally is that the allied health professional is more resistant to it. The feedback I got from another OT was that's why I did my degree, and they didn't do my degree, which didn't sit right with me, but I had to respect it at the same time. So what we're doing is just canvassing what are others doing and what does this sit ethically. And the way we interpret it is that it's based on risk, and the higher the risk, then we need to be a bit more accommodating with how we do it in order to reduce that.
Does anyone else have anything they want to add to that particular topic based on other experiences? No? Well, Evan, you're absolutely right. Oh, Kylie's popped that in there. The risk, obviously, that's associated with it has to be weighed up, but it's that great step that you've already put in place, having those AHA shadow OTs, so they're getting quite familiar with the processes that they may be conducting out in the community when the AHP isn't physically present with them. I do find particularly community-based stuff, you will have a lot of pushback from allied health professionals to delegate tasks or allow support from AHAs. I find physios not so hesitant to hand over or delegate, but most of the other allied health professions in my experience have been a lot more hesitant to hand over. In terms of, I'm just throwing an elephant in the room here, in terms of their comments of, we went to uni for 4 years to learn how to do this. Yeah, but there's a lot more to it. I'm pretty sure they didn't measure the height of a step for 4 years, where they were calculating what angle of a ramp and everything needed to be there, or what length of ramp needed to be there. There's a lot more about their clinical judgment, their reasoning, the report writing, the justification of why accommodations need to be put in place, particularly from that OT perspective. So I guess reinforcing to the allied health professionals that it's not just the field work or the hands on the ground that they actually train for, it's the huge other component, which is what actually makes a difference in people's lives as well. That's what they've also trained for, which we haven't necessarily as AHAs. So we can do that work on the ground to support them while they're doing all that clinical justification, that reasoning, that report writing, sometimes those trialling of the equipment and accommodations to support those individuals out in the community. Does that make sense?
Yeah, that's great. That's very validating for comments I've already passed back to that particular staff member. So that's really helpful. Thank you. No
problems at all. Okay, moving back to Karen with the CTIs for paediatric specific, looking for community and disability related. I feel like this would be such a hard area to do CTIs for because it is so broad. I guess, are we looking at physio-specific, OT-specific, speech-specific, multidiscipline? Like that's one aspect to look at, because I find with paediatric community disability, there is so much crossover of disciplines rather than having stuff specific for one discipline or specific for one disability or one type of intervention, like working on handwriting skills and stuff like that. So are we looking multidisciplinary or? Yes, I can see you nodding.
Yes. multidisciplinary but also like discipline specific. I didn't know if it would be sorry, like I've got some like screening things that we often do, like a toileting screener or sensory profile. That's just like entering the data basically, which I think would be fine for a CTI. But then other assessments like a deep or a Nuffield or a movement ABC, because some of those involve more of a clinical judgment, they would probably not be appropriate.
Yeah, so some of those assessments, particularly when you look at disability as well, because they do need that judgment on the go, it depends on the individual. If it's just data collection that the AHA is doing, that's a lot easier, obviously. But if there's the observation of how they're physically doing something that needs to be recorded, that could potentially still be administered by an AHA while being videoed. So the allied health professional could review the video when they're writing the report and justification on there. But some of those more complex assessments or complex clients would potentially still need the allied health professional. If you look on the other aspect, rather than just doing assessments, you look at more common allied health interventions for that pediatric disability sort of setting. So handwriting is a huge one. So working on handwriting or scissor skills and stuff like that. So what is the general progressive pathway for teaching someone scissor skills? You're not just going to chuck scissors straight in their hand. You might start with tearing paper. Then it might be getting the motion, building the hand strength and stuff like that. So just some general tasks associated with developing scissor skills. Can we tick them off that the AHA knows that progression and is competent to be able to assist someone to do it? So yeah, if you're looking at some more common things that would be delegated to an AHA, then yeah, building those CTIs for those competencies may be a good place to start. And then yeah, you could start looking at some of the higher level as you get more okay with those CTIs.
Yeah, right. Yeah, something maybe like development of speech or language.
Yeah. So that
when you're talking about like timelines of what should be happening when, you know.
Yeah. So if you start looking at like articulation or speech sound errors, can they identify that speech sound? Can they say it in isolation? Can they say it with different sounds before and after, like medial position, end position, start position, all that sort of stuff. So breaking it down by what the progression is of that particular skill, and they understand the progression, that would potentially be how to develop those CTIs for that sort of cohort of clients.
Beautiful. Thank you for that. I was really stuck in a rut about like, I don't know what I'm doing, but I do, because I do it.
You do, but you do know what you're doing.
I don't know how to articulate, but I know how I'm doing.
Yeah, look, just break it down into steps. Those CTIs for that particular cohort, I guess, the community disability pediatrics, because there is so many aspects for it. If your AHA understands that progression for it, like where you start and moving your way through, then they're more likely to be able to deliver that sort of program to most clients, because they know, oh, do we have to step it up, step it down? Where are they at? Sort of thing.
Beautiful. Thank you.
You're very welcome. All right, moving on to our next question in the chat. What tasks do other AHAs do for dietetics, support works, nutrition, and PH? Fiona, is that pharmacy, public health? What's your PH there?
Yeah, so dietetics, social work, nursing and pharmacy.
Nursing and pharmacy. Ooh. All right, I'm throwing this one open to the room. So anyone work in the dietetic support work, nursing or pharmacy in a community or outpatient clinic in government health? Anyone? Anyone willing? No, we haven't got anyone in the room. That's a no. Fiona, it's all you. Would you like to share what you're doing currently in that space?
Well, I currently don't, we don't really do anything for dietetics, social work, nursing or pharmacy. So I was just wondering if anyone else did, to see if we could add to that.
Interesting. But not in the community space. Kylie, you start talking.
So I think because the supervision and delegation framework is coming from an allied health professional, I think we need to steer clear of a nursing delegation. So that's my first thoughts. Pharmacy, are they in a different, I'm not too sure about pharmacy because are they allied health?
Yeah.
Okay, that's all good.
But we, like, it's just in community, it's not in a hospital setting. So I know there's loads of pharmacy assistants on inpatient, and, you know, they do lots of, you know, stuff with moving medications around and, you know, filling up stocks and all that kind of stuff. But yeah, I was just curious, that's all.
I mean, when I've worked in a home-based setting, I would liaise with a pharmacist, but it wasn't a formal like task delegation or anything like that. It was just more keeping the pharmacist in the loop if the client had questions or something.
Yeah, which is what we do. Yeah.
Okay. Yeah.
I just wondered if anyone did anything else, to see if we could, if we're missing something.
Thank you. Tara, you want to add on to that?
Hello, I'm sorry to jump in. So I've worked in a hospital pharmacy practice setting for a long time now, and most of my work has been in advanced scope pharmacy technician delegation activities. We tend to tap in and out of the allied health sphere, depending on what organisation we're employed by. So in SA Health, where I worked previously, pharmacy assistants are employed as allied health assistants, but here in Tasmania, where I work currently, they are very clearly not employed as allied health assistants. So it does depend a little bit on the jurisdiction in which people are employed in. And then in a community pharmacy setting, the employment agreement is very clearly not considered allied health assistant. They're employed as retail pharmacy assistants or as dispensary assistants. But that being said, there is a lot of work that has happened in the delegation space. So pharmacy technicians participating in final accuracy checking of inpatient medicines in particular is a really big one. So that traditionally has been a pharmacist scope activity, but has been safely delegated in New Zealand, UK and US for a significantly long time. And we're doing some pilot programs here. I know that Alfred's, all their inpatient activity is done by pharmacy technicians, so with no pharmacist accuracy check at the end of those activities. And then other spaces, the space that I work is more in the clinical space, so pharmacy technicians being delegated the activity of medication history taking, so interviewing patients and collating all of their medication history so that the pharmacist can then do that clinical review. That probably is the bit that most similarly replicates the work that happens in community pharmacies at that like more experienced level. The terming framing, just there's quite distinct. Pharmacy is a weird niche area where there's quite distinct differences between how community pharmacy and hospital pharmacy sectors operate, but there's definitely a lot of work happening in that space, so I'd be happy for anyone to reach out to me if they'd like as well.
Wonderful. Thank you so much for sharing that. And we've also got Karen's just popped in the chat there as well with dietetics, that they're able to do the height and weight measurements as well as the pediatric malnutrition screener. So yeah, from the sounds of what Tara was just saying as well, is again gathering that data, that information for the actual allied health professionals to make those judgment calls or assess what's actually happening. Fiona, just also on that, what I'm finding over here in Western Australia, because I know you're down in Albany, aren't you?
Yes, I am. Yep.
Yeah. What I'm finding over here, we don't have a huge amount of dietetics or nutrition AHA-based work. And when they do advertise them, believe it or not, I've seen 3 advertised in the last week, they're looking for AHP students rather than actual AHAs, which has also been historic. And looking at them, they've always been hospital-based, and it's always been advertised predominantly around their meal selections and knowledge of the food preparation processes and stuff like that in hospitals.
They have here in Albany in the hospital, because I used to work in the hospital as well, dietetic assistants, they're called that, but they're not an allied health assistant, they're just a dietetic assistant, which I've also done a Cert 3 in dietetic assistants years ago, because I used to work in the hospital kitchen, and essentially, like you say, they're mainly just running the menu stuff for the kitchen, with just talking to the dietitians in the hospital around the special needs of the patients. So yeah, we do like the M&A screening and stuff like that, and heights and weights, but not on a regular, but it's different in community, but it's all good.
Yeah, definitely. And same with social work. I don't see a huge amount of uptake for social work in the AHA space over here. I know it's quite big in Queensland and ACT. Is anyone else online at the moment that does any social work kind of activities or delegation? Kylie.
Yeah, we've got a lot here at Monash Health. We've got dedicated
excellent.
social work AHAs working in the acute setting. Not so much, haven't quite gone into the community setting. Sorry, in the acute setting mainly, and the subacute setting. And even we have AHAs doing things like organising VCAT hearings, which is and it's probably specialised for Victoria, but and helping clients find aged care centres, and lots to do with the paperwork, supporting the social workers.
Yeah, thank you. There's not a huge amount of uptake of that in Western Australia at all. Social work doesn't very often utilise AHAs.
When I worked on the ward a few years ago, we did stuff like mindfulness for certain people and some colouring in.
Yeah.
That kind of stuff, but not in community outpatients.
Yeah, no, definitely. Though the Cert 4 qualification now has the unit support relationships with families and carers as a core unit, which is more around the social work aspect, depending on how well it's delivered as to how that goes. But yeah, it's something that needs to be, I guess, incorporated more nationally. But that's from an organisational perspective as well, not just from a training perspective, to look at utilising our AHAs across more disciplines rather than the predominantly physio, OT and occasionally speech as our main ones.
Yeah, I agree.
Yes, we'll advocate for that. And look, in those regional type settings, they generally do utilise their AHAs a little bit better, or across other disciplines in comparison to more metro-based settings, because you're that rural generalist type environment. But you know, we can always do better across metro and country sort of settings. Keeping in mind we've only got about 10 minutes left to go. Does anyone have any other questions or anything they would like to contribute, share, discuss? Feel free to pop up your hand or pop something in the chat if there is anything. Ty, do you have anything you would like to add or ask?
Was that me?
Oh, it's Ty.
Oh,
It's been
Ty,
sitting there very
sorry, I thought you
quietly
said
watching
Kylie.
us the
No,
whole time.
No, I was just trying to. Sorry, I was just responding to emails, trying to get people in. No, it was great. No, thank you. Just trying to. I'll get back to you, Corey.
Okay, thanks. Well, Kylie, did you have anything else you wanted to add?
No, just to thanks for putting up with me. I came here to learn something. I've learned a lot already because I'm very Victorian hospital based, and I'm really keen to learn about what's happening out there in Australia. So it's really great to hear everyone's story. So thank you.
Yeah, it's interesting to see the way that things operate, or how it operates across the country. Although the training should be fairly standardized, it's not, but it should be. There is so much variance happening across the country, and even in government settings. Like, you'll have a government setting in one state compared to another, and they're doing it completely differently. Or like our delegation process in metro government health is from 2009 or something. It hasn't been updated in 17 years. So like, when we're training the courses, we actually use a lot of South Australian health, Queensland health sort of resources that are readily available. And Fiona, thank you. WA Country Health Service Allied Health Assistance Policy is a great one that we utilise across a lot of units. But yeah, we utilise stuff from other states quite often in our training because we haven't got enough relevant, up-to-date, current resources in our own state to be able to utilise. It's very interesting seeing all the different things, the way things are operated or done elsewhere. Kylie, I will let you respond to Kim there with your email address. Perfect. Well, I'd like to thank everyone for joining us today and participating, asking questions, contributing, or just listening to us ramble on. I hope it's been of benefit for at least some of you in the room today, and really appreciate you taking the time to join us. But other than that, I don't have anything else to add. So please do enjoy the rest of your day. Keep being amazing and doing the fantastic work you do. Well, most of you are AHAs, so keep being amazing.